I think we're ready to go. Welcome everyone to this evening's session, Managing Asthma in Spring. Before we begin, I'd like to do the acknowledgement of country. Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians on the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boonwurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islanders in the session with us tonight. Just a little bit of housekeeping. All attendees have entered on mute. Please ask questions via the Q&A box only. Q&A will be at the end of each presentation. We have two separate small presentations tonight. The session is being recorded, so questions will be asked anonymously to protect your privacy. We do ask that when you enter the session, you ensure that you've entered the session with the correct name that you're registered with. So you'll be able to change your name if actually you probably can't change your name with the webinar, but all participants will need to come in with the correct name. Otherwise, we won't know who you are and we won't be able to allocate your CPD points. So if you haven't entered with the correct name, you might have to exit and come back again. If you are not sure if your name matches, you can also send a message in chat, and Jen, who's doing our back-end support tonight, she will ensure that she records that you're attending. Before we begin our presentation, just wanted to touch base and just, I know a lot of the clinicians here have probably all heard about health pathways, but if you haven't heard about health pathways and you would like to have a look at health pathways and start using it, please visit melbourne.healthpathways.org.au. You can register by the QR code on the screen at the moment, or you can send us an email to info@healthpathwaysmelbourne.org.au. What is health pathways? Well, pathways are written by GP clinical editors with the support from local GPs, hospital-based specialists and other subject matter experts. You will receive clear and concise evidence-based medical advice when you look at the pathways. It reduces variation in care, how to refer to the most appropriate hospital, community health services or allied health providers, and what services are available for your patients. Here's just a list of some of the pathways that you will find for relating to tonight's session. But if you do visit the health pathways, you'll see there's a lot of pathways on asthma and everything listed there. So I will welcome our speaker tonight, Narelle Williamson, Senior Clinical Consultant at National Asthma Council. Narelle is a registered nurse and a respiratory educator with over 25 years of experience in acute hospital settings and primary health care. She has developed nurse-led respiratory clinics in primary care. For the past 12 years, she has been educating and consulting with patients in various primary health care settings in Melbourne's East. Prior to her current role, she was a nurse manager at a large and highly regarded general practice in the Melbourne's East for 15 years. Narelle has enjoyed travelling Australia for the past decade, educating GPs, practice nurses and pharmacies in respiratory health. She now also manages the Asthma and Lung Health Education Best Practice for Professionals program with the National Asthma Council. Welcome, Narelle.
Thanks, Yvonne. That's a mouthful, isn't it?
It is. Done it all in one breath.
Well done. Thank you for having me. Thank you, everyone, for joining after I'm sure everyone's had a long day and it's turned a bit wintry in Melbourne again as well. So tonight you may have been a part of this webinar in previous years. We converted all our face-to-face workshops into webinars when COVID decided to hit. So this one is running through allergic rhinitis and asthma in spring, typical allergies, and then we'll talk about thunderstorm asthma in the second half. So I will share my screen. I always turn my video off. It just saves a bit of broadband, a bit of bandwidth from my end. but I'll just bear with me while I share everything here.
Great, we can see that in presentation mode now, Narelle.
Great, perfect. All righty, here we go then. So our learning objectives for tonight are that we are going to describe the association between allergic rhinitis and asthma. We'll summarise the treatment guidelines for allergic rhinitis and describe those people who are at greater risk of thunderstorm asthma and the guidelines of management. And then we'll summarise the importance of written asthma action plans and asthma first aid in thunderstorm asthma season. This is our asthma handbook website, which I always like to remind people about. It's updated every year. We have minor versions and major versions. The last version update is 2.2, launched in April last year. We're currently updating again. And our guidelines are written by a committee of respiratory experts, and they're converted into practical guidance, I guess, for us health professionals. The handbook is available free online for everyone to access. So I really encourage you to jump on there and have a look. Anything and everything regarding asthma, allergic rhinitis is in there. And for any of the resources that you see tonight, you can order those from the National Asthma Council website, or you can download a lot of them now actually and print them as PDFs. And our education program is in there. So basically our resources, if you're wanting any of those. So we'll start off, as I said, with allergic rhinitis and just run through a few facts, what it is, etc. So approximately 19% of us Australians suffer from allergic rhinitis, or in layman's term, hay fever. And in comparison, about 11% of people in Australia have asthma. So relatively speaking, 19% with allergic rhinitis is a large number. It's often underdiagnosed and undertreated and suboptimally self-treated. And allergic rhinitis is most common in people aged between 15 to 54 years. It's an independent risk factor for developing asthma in both children and in adults. And the presence of allergic rhinitis is definitely associated with worse asthma control. Most people with allergic rhinitis are sensitized to multiple allergens, for example, both pollens and house dust. So symptoms, therefore, may be present throughout the entire year. And the most common allergens are house dust mite, pollens from grasses, trees, or weeds, animal dander, and mold spores would be the most common. Both rhinitis and asthma can be triggered by the same factors, whether allergic factors such as pet allergens, pollens, house dust mite, cockroaches even, or it might be non-specific factors such as cold air, strong odours, tobacco smoke, etc. And allergic rhinitis and asthma commonly coexist. It's sometimes referred to as the United Airways disease, where asthma, of course, is inflammation of the small lower airways, and allergic rhinitis is inflammation in the epithelial lining of the upper airways. So allergic rhinitis occurs in more than 80% of patients with asthma, and asthma occurs in about 30% of patients with allergic rhinitis. So therefore, it's understandably very important to assess patients with rhinitis for coexisting asthma and then treat both of those conditions at the same time. Some patients can actually mistake symptoms for allergic rhinitis for asthma or vice versa. And rhinitis is sometimes more easily recognisable only after asthma has been stabilised. So if we're thinking about assessing patients for allergic rhinitis, we assess for common symptoms, which can be categorised into local, regional and systemic. So local symptoms are those things such as nasal discharge, congestion or itch. Regional symptoms generally affect the ears, our eyes, voice and throat, cough from postnasal drip, those sorts of symptoms. And then we have the systemic symptoms, which include lethargy and sleep disturbance. The frequency of symptoms of allergic rhinitis can be seasonal or they can be perennial. Seasonal, obviously, as the name suggests, are seasonal, mostly in spring and summer, and triggered usually by the pollens. Perennial or non-seasonal, year-round frequency of symptoms, they're triggered by indoor allergens such as the dust mite, the animals, and the molds. When we think about impact of symptoms, if someone's diagnosed with mild allergic rhinitis, there's generally not much effect on their day-to-day function. It's still annoying, but generally they can go about their daily activities. Whereas if they have moderate or severe allergic rhinitis, they do have impaired day-to-day function and even sleep disturbance. So it's important to identify every patient's individual triggers, and that might not just be the grasses or the animal danders or pollens or dust mite. It might be occupational triggers from chemicals or irritants or fumes. And these are picked up because people, when they move away from their workplace, the symptoms usually resolve. So spray painters, for example. So then we would conduct a physical assessment. We would inspect the upper airway for swollen turbinates, transverse nasal crease, as you can see in the diagram there of the child, where you get that frequent, or they frequently rub the nose up in an attempt to relieve itching. And then you get that allergic salute, that nasal crease across the top of the nose there. And other physical things might be reduced nasal airflow, or they could be mouth breathers only. Dark circles under the eyes will always indicate sinus congestion, or they might tell us that they have sinus pain. So it's important to take a history of relevant coexistent conditions of asthma and eczema. Asthma, eczema, and hay fever are very, very closely linked. So take a history of all of that, and genetically as well. So first line, so parents and children, take a history of any parents or children who might have any of those three conditions also. So when we look at diagnostic investigations to diagnose allergic rhinitis, there's two main allergy tests. And these help to identify the allergens and enable more of a precision approach, I guess, to managing that trigger. So the gold standard test now is serum-specific IgE blood tests. So they obviously detect specific IgE antibodies, which are made by the body's immune system against allergens. The blood test, you may also have heard it be called the RAST test, R-A-S-T, RAST test. So the GP or health professional ordering the IgE or RAST blood test needs to write specifically what they would like tested. Otherwise, just a small panel of tests is completed. So if a GP just writes RAST test on the path form, that might only include dust mite, cat, and mold. So if they're wanting to test for dog or horse or cockroaches, they need to write that on the path form. So that's an not interesting, but an important thing for you to know, and you can pass on to GPs or other health professionals writing the path forms. And the second allergy test is the good old skin prick testing. Not so commonly performed in GP clinics anymore, but I've certainly performed a lot in my years, but more commonly now in an allergy specialist clinic. That's where the small amounts of different allergen solutions are applied to the forearm or to the back if we're testing children. And the skin is gently pricked with the sterile lancet. And if a patient has a sensitivity to that allergen, the skin swells or develops a welt, such as in the forearm picture that you can see there on the screen. And it's always important to educate your patients to tell them that they should avoid antihistamines for 3 to 4 days prior to allergy testing. So it's really important for patients to speak to a health professional, their GP, their practice nurse or respiratory nurse, their allergist. They shouldn't simply rely on over-the-counter remedies for their allergic rhinitis treatment. So I'll run through this list here of the extensive amount, and it's getting bigger by the day, of treatments that are available out there. And the first and most important treatment is the INCS, or the intranasal corticosteroid sprays. These are the most effective treatment for anyone with persistent or moderate to severe allergic rhinitis. And that's because they reduce inflammation in the lining of the nasal passages. They reduce swelling and they also reduce mucus production in the nose, and they can also reduce ocular symptoms as well. Some intranasal corticosteroid sprays are available without prescription. Nasonex, for instance, now, it used to be only available on script and cost almost $70 about a decade ago. Fortunately, now you can buy it over the counter. So that's a great benefit. Stronger versions are still available on script. So these intranasal corticosteroid sprays should be taken regularly and long-term, just like our preventer medications for asthma. They don't provide immediate relief from symptoms. In fact, patients won't feel relief for up to 2 weeks. Therefore, it's imperative that patients stick to their dosing regime to gain maximum benefit. A lot of patients of mine start Nasonex and they think after a few days, oh, it hasn't helped. Well, that's correct. It hasn't helped because it takes 2 weeks for it to start to work properly to decrease that inflammation in the nasal passages. So they need to be really strict with themselves and stick to their regime. Next on the list is the antihistamine nasal sprays. These are all available over the counter. These can provide quick relief of symptoms such as itching and sneezing, and some of them may help with a blocked nose, and relief is usually within 15 minutes. They are not as effective as the INCS in controlling that severe nasal congestion and drip, and they don't need to be used regularly to be effective, but they can be used as symptoms arise, and most of them can control symptoms for up to 24 hours. Then we have the combination nasal sprays. As the name suggests, it's a combination between the corticosteroid spray and the antihistamine spray. So we have Dymista, which is now available over the counter as per July this year. And then we have Ryaltris. They're the two most common. Ryaltris is still scripted. And these sprays give the advantages of both the intranasal corticosteroid and the antihistamine. Then we have the good old antihistamine tablets, your Telfast, your Claritine, your Zyrtec. And these are effective for controlling itching and sneezing, but a lot less effective for clearing a blocked nose. So if the response to an intranasal corticosteroid alone is inadequate, despite regular daily use and correct spray technique, you could add an intranasal antihistamine and continue that intranasal corticosteroid. And they're not mentioned here, but I do like to talk about, just quickly, decongestant nasal sprays. These tend to be quite popular, not only the sprays, but the tablets. Obviously used to unblock the nose, but they actually shouldn't be taken for more than a few days at a time, as they can actually begin to have a rebound effect and cause nasal passages to become inflamed and swollen and congested. And obviously that's exactly the opposite to what we want to happen. So they can be useful for a couple of days, but any longer than that, they start to have rebound effects. Then we have the lovely saline sprays and rinses, which are definitely not the most pleasant procedure, as one of my sons can attest to, but they can be very effective. They help to flush away allergens and irritants from the nose and keep the nose clear by loosening and thinning that mucus. And when symptoms improve, any of these treatments can be reduced. Allergen avoidance is obviously advised once that allergen or allergens have been confirmed. Then there's always the option of allergen immunotherapy, or otherwise known as desensitization. That can be a preferred option for some patients rather than long-term use of medications and sprays. And of course, immunotherapy or desensitization is that regular administration of the commercially available allergen extracts. And these days that can be sublingually or subcutaneously. So it's great that the option for sublingual is there now. So this promotes clinical tolerance. Treatment is usually for 3 to 5 years to produce ongoing benefit. It's the only treatment that can alter the allergic response. So it's quite a commitment, obviously, given that timeline. It requires referral to an allergy specialist, but a lot of my patients have gone through it and wouldn't have it any other way. Yes, it's a commitment to come in once every couple of weeks, sort of spans out to once a month, but obviously a commitment and quite pricey. But at the end of the day, if their allergens are then controlled, it's a great outcome for them. We always avoid oral corticosteroids with allergic rhinitis. They're just not justified due to adverse reactions such as increased clotting and hypertension, so we don't use those. And we're going to move on to talk about the allergy treatment plan on the Askia website. But I do also like to mention that on the NAC website, that second website I showed you at the start, we have a library of how-to videos where we demonstrate and supply information on correct device use for not only asthma medications, but for allergic rhinitis treatments. So the nasal sprays, the sinus rinses. A lot of patients aren't told how to use their nasal sprays correctly, and they can have repercussions, such as with the intranasal corticosteroid sprays. A lot of people don't direct their sprays away from the nasal septum. Our nasal septums are very vascular, and so they get a lot of blood noses. And that, of course, leads people to think, well, I'm not going to use this. You know, they don't want constant blood noses. So it's important for patients to be educated correctly. And if the practice nurses or the GPs or the pharmacists haven't had the time or the knowledge about correct device technique, our how-to video library on our website is really useful. So these are two allergic rhinitis treatment plans. On the left is from the NAC, and on the right is from Askia, the Australasian Society of Clinical Immunology. And these charts are the two main charts that are used in allergic rhinitis treatment, but also for asthma. So patients with intermittent symptoms that occur seasonally, this is looking at the left-hand side chart now from the NAC, they may only require treatment for a few months of the year. If they've just got seasonal allergic rhinitis, they won't need year-round treatment. While others with severe symptoms related to pollen exposure, or if they've got a house dust mite allergy and a pollen allergy, they may need treatment throughout the entire year. On the right-hand side is the, as I said, the allergic rhinitis Askia chart. And that just runs through the different medications. It's more like an asthma action plan where they get filled in with the amount of sprays that a patient should be taking, a little diagram there of the correct way and the incorrect way to take nasal sprays, et cetera, down to the bottom of the page. If symptoms get worse, how to increase or change the medications. So two great resources there for you guys. This is the current allergic rhinitis treatment chart as of August last year. Demista, as I said, now is available over the counter. And there are also two more medications that are coming onto this chart. So whilst I say it's current at the moment, which it is, it's going to be updated, I think, in October, if all things go well. The other thing I love about this chart is down in the left-hand corner, you can see the QR code. That is a QR code direct to that how-to video library that I told you about. So like the asthma and COPD medications chart, this chart is getting more full by the month with so many more medications coming onto the market. You might recognise Jen here in this picture. Jen used to work for the NAC. She's here tonight. So these are just another couple of our resources that we have available on the website. But fantastic resources for patients and for health professionals. The left-hand side is actually a tear-off pad, and it has the flow chart as well as all the medications and a bit of an action plan. The other one is just an intranasal spray technique as another option as opposed to our how-to library. So if we haven't seen a response to treatment trials in our patients within around 3 to 4 weeks, we may need to look at referring our patients onto a specialist. Their allergic rhinitis symptoms may be persisting, their symptoms may become more severe, and there's just no response to treatment with the intranasal corticosteroid sprays or combination sprays. We might find that our asthmatic patients may be experiencing persisting or increasing symptoms, and they just don't have good asthma control despite regular preventer medication, good adherence, and good inhaler technique. So then we'd be referring on to a specialist. We may think that if other allergic diseases such as eczema is present, then we'd probably refer off. If a food or an occupational allergy is suspected where symptoms are worse in the workplace, then we'd also probably refer off to a specialist. And remember, guys, that referral may need to be for an ENT specialist. It may not be an allergist. This could be for complications such as resistant obstruction, sinus disease, ear problems, persistent purulent discharge, anything like that. There could potentially be a polyp that's unresponsive to initial intranasal corticosteroid spray therapy. So for any of those reasons, always think about referring on. And of course, immunotherapy, you need to refer on to in order to get the allergens ordered. So that covers allergic rhinitis in a nutshell. Are there any questions regarding allergic rhinitis before we move on to thunderstorm asthma?
No, there's nothing at all, Narelle.
No questions? I don't know if that's a good thing or a bad thing, whether I've completely bombarded people or I've lost people. I'm not sure. Well,
no, everyone's still here, and it looks like you've probably got a very comprehensive presentation. No questions needed.
All right. Well, we've got another chance at the end, everyone. So think of a couple of questions for the end, if you like. Okay, we'll move on then. So we'll talk about grass pollen and thunderstorms. And grass pollen season in Southeast Australia typically occurs from October through December. So even though spring clearly starts in September, our pollen count doesn't start until October. So we say that grass pollen season is from October through to December. And it brings a seasonal increase in asthma and allergic rhinitis, and it also brings the chance of thunderstorm asthma. Thunderstorms throughout October, November, and December can trigger asthma in people with grass pollen allergy, even if they've not had asthma before. And thunderstorm asthma can also affect those with known asthma, past or present, or those just with seasonal allergic rhinitis only. And this slide shows us a timeline of the thunderstorm asthma events in Melbourne over the past 4 decades. I'm sure most of you here tonight will remember Melbourne's November 2016 thunderstorm asthma event. It was actually the largest and the most devastating ever recorded worldwide. So we had severe thunderstorm activity in Victoria it was the 21st of November, which led to thousands of people suddenly having asthma exacerbations and finding it hard to breathe. Our emergency departments, Ambulance Victoria, were overwhelmed by the volume of asthma sufferers who presented needing urgent attention at the one time. And the median age of the majority of those affected back in 2016 was 32 years of age. So also interestingly to note in this slide is that the history of all of these events is in the month of November. Also, the time of the events is interesting, and therefore the presentations to ED. So let's take 2011, for example, presentations to emergency departments at around 3:30 in the morning. So the middle of the night, only 30 ED presentations. People, you would think, majority of people would be home in bed, tucked up, sound asleep. Whereas in 2016, the thunderstorm rolled through at about 6 p.m. in the evening. And there were more than 3,400 attendances or presentations to emergency departments. So people were coming home from uni, they were out playing sport or training for sport, or, it's daylight savings then. People are out and about and probably enjoying the nice day that it was before this thunderstorm rolled through. And you can see that there's been other Australian episodes there as well. So following the November 2016 epidemic thunderstorm asthma event, not only were emergency departments and Ambulance Victoria affected, but general practices in the Melbourne metro area experienced a considerable impact as well. Over the 3 days from the 21st to the 23rd of November, there are an estimated 10,000 additional asthma cases visiting a general practitioner. And in the 30 hours following this event, there were 3,400 extra emergency department presentations to public hospitals in Melbourne and Geelong, which is a 672% increase above the 3-year average. There were 500 extra admissions for asthma to public hospitals in Melbourne and Geelong. there were 30 ICU presentations, and tragically, there were 10 deaths. So not only were emergency departments, Ambulance Victoria, general practices inundated, there was also a large surge in pharmacy presentations as well. And as you may remember, salbutamol or Ventolin was in very short supply. In fact, a lot of pharmacies ran out, as did some of the public hospitals. And 2/3 of the people who presented to hospital didn't know that they were suffering asthma symptoms. But when questioned, a further half of those people reported having had previous asthma symptoms, those typical symptoms such as shortness of breath and cough, wheeze, or nighttime waking with either cough or wheeze, but they'd not thought much of it until this thunderstorm asthma event occurred. And then after this event, some patients were discharged without proper follow-up, or they failed to make a review appointment with their GP. So for a thunderstorm event to be significant, it needs to be a high pollen day. And it's not all spring thunderstorms that lead to thunderstorm asthma. It's also dependent on change in humidity and a drop in pressure. So I mentioned about all the events being in November, and that's because the perennial ryegrass crop has been implicated in all of the Australian thunderstorm epidemics. Fungal spore can also contribute as a risk for some people. But the Australian Bureau of Meteorology Victorian map back in 2016 from September through to December shows light purple and dark purple shading that you can see there on the map, representing higher levels of rainfall from September right through to the end of November, start of December. And this high rainfall back then in spring enhanced prolific growth of grasses and therefore pollens right throughout the state. So this slide shows a visual representation of one hypothesis for the mechanism, if you like, of thunderstorm asthma, and how if it's also a high pollen count day, it can deposit smaller than usual particles in the air and have the potential to cause problems for those with asthma and or hay fever. So whole pollen grains get swept up into the cloud as the storm matures. And these pollen grains are usually around 10 micrograms in size, and they're normally filtered by our nose. Then the moisture in the cloud fragments the pollen into smaller pieces, can be less than 2.5 micrograms in size. The downdraft or the cold dry outflow then carries these much smaller pollen fragments to ground level. And they're so tiny that they can't be filtered in our nose. So therefore, they're easily breathed into our small airways. And the strong wind gusts that precede a thunderstorm provide that very efficient mechanism for exposing large numbers of people to lots of pollen allergens suddenly and at the same time. And then, depending on the storm's movement, these gusts may travel over large areas before diminishing. Then huge numbers of people are affected by asthma symptoms at similar times. That's where we get the term epidemic thunderstorm asthma. This is just a little video of those pollen grains rupturing, if it'll play for me. So remembering those bigger pollen grains, they're supposed to be, 10 micrograms approximately in size. And you can see when they rupture that the little pollen particles that it fragments into are much, much smaller and therefore easily breathed into our smaller airways because our noses can't filter them. So this all occurs in the ryegrass pollen season between October and December, but the majority is in November because that's when the ryegrass has matured. So if we look at the categories of people of those who are at increased risk of thunderstorm asthma, they include people with sensitization to ryegrass pollen, people with seasonal allergic rhinitis related to grass pollen who have asthma or who have never had asthma. Then there's people with asthma, especially if they are poorly controlled or not taking their preventer medication. Then there's people with a past history of asthma. For example, someone might have had childhood asthma and they still may have that hyper-responsiveness, if you like, in the airways. And then due to the very small pollen particles, their old asthma gets triggered. Then there are those people with undiagnosed asthma. And the risk increases even further in patients with both asthma and allergic rhinitis who are poorly controlled or who have previously been admitted to hospital, particularly to an ICU. So these high-risk categories of people, when exposed to open air before and during a thunderstorm in pollen season, or who live in areas prone to high pollen, are all at increased risk. And evidence from the November 2016 event suggests that the higher risk is definitely in the southeast and South Australian populations. So it's really important for us as health professionals in the southeast of Australia, in Melbourne, to be really aware of thunderstorm asthma and educate our patients and fellow health professionals. So one of the big risks regarding thunderstorm asthma, is that for many people it's completely unexpected. So they may not have awareness of or access to reliever therapy, such as salbutamol or Ventolin, or an action plan to help keep themselves safe. And that could be an allergy action plan or an asthma action plan. So general advice, not medical advice, we'll go through that in a moment, but general advice for all of those categories of people I mentioned who are at risk: should avoid exposure to outdoor air when the pollen count is high and a thunderstorm is predicted, particularly just before a thunderstorm, especially during the wind gusts that precede the rain front. And we need to educate patients on the different pollen counts and forecasts that are available. In Melbourne, we obviously have the Melbourne Pollen app. We can listen to our daily news broadcasts and weather reports. From the 1st of October, they'll be giving a nightly pollen count update and also a thunderstorm asthma prediction if it's likely in the next few days. There's the Oz Pollen app, and that's relevant to each state or territory. So as I mentioned, that's Melbourne Pollen for us. There's also the Air Rater app, which talks about air quality. There's the Vic emergency website as well. So those would be the ones that are relevant for our audience tonight. Other general advice is for patients who are at risk to remain inside their homes or their work building or their car with windows closed, turn off air conditioning or at least use it on recirculated air on high pollen days or predicted thunderstorm event days. If someone is experiencing any signs of asthma, they should follow a personal written asthma action plan, or if they don't have a personalised action plan, then they need to follow the first aid asthma steps, which we'll go through shortly. And obviously, if asthma symptoms are rapidly worsening, they need to call, or someone else needs to call 000 and state that someone's having an asthma attack. So medical management for those patients who have asthma and also allergic rhinitis, we need to be proactive with these patients leading up to spring. We shouldn't wait for something to happen. They shouldn't wait for something to happen. They should arrange a review appointment and renew their written asthma action plans and their written allergy plans. We need to, of course, ensure correct diagnosis. So you might be wanting to perform a spirometry again. Diagnosis of asthma and or allergic rhinitis. Don't leave one or the other out. Assess for both. The patients need to know and understand the management of their identified triggers. We need to address lifestyle and medical management of both conditions. We need to talk to them about taking their prescribed medications, really educate them about understanding their reliever therapy and their preventer therapy and the importance of adherence. Also educate them on the correct device technique. There's no point someone telling us that they've got good adherence, and they may have good adherence, if they're not taking their medications correctly. We'd also provide advice for high pollen days and thunderstorm events. We would manage and regularly review their asthma treatment following the current asthma guidelines from the handbook. And the most current guideline is that most people with asthma should be using preventer therapy, even people with mild asthma. So as of 2021, people with mild asthma should not just be having salbutamol, i.e. Ventolin, Asmol, or Bricanol. They should be on a preventer medication. Only very few people should be managed with reliever alone now. In fact, only those who experience symptoms less than twice per month should be on reliever medication alone. So if they're not already on a preventer medication, they need to commence one, preferably 2 weeks before pollen season, and maintain that use right through until the end of December. Of course, they should also carry a reliever medication for acute symptoms should they arise, and make sure that it's replaced before the expiry date or before it's nearly empty. I'm sure we've all seen patients come in with expired or almost empty canisters, but they need to really be educated to have a preventer. We also need to encourage proactive treatment of that allergic rhinitis. And again, just like the preventer medications for asthma, if they have allergic rhinitis, they should be starting an intranasal corticosteroid spray at least 2 weeks before the pollen season commences, and then continue right through again to the end of December. I've already mentioned written action plans. All patients with asthma and or allergic rhinitis should have one or both. And there's actually insufficient evidence to prove that intranasal corticosteroid sprays protect against thunderstorm asthma, but evidence does exist that lack of inhaled corticosteroid preventer for asthma is a risk of thunderstorm asthma. So no evidence to prove that the corticosteroid sprays for the nose protect against thunderstorm asthma, but there is evidence that corticosteroid preventer inhalers is a risk factor for thunderstorm asthma. I hope that makes sense. So medical management now for those patients with allergic rhinitis only, so no asthma, just allergic rhinitis. We would manage these patients as per the current allergic rhinitis guidelines. So we'd identify those people with allergies to grass pollens, treat them with the intranasal corticosteroids again at least 2 weeks before, and continue right throughout the pollen season, so mid-September right through till the end of December. And these individuals with allergic rhinitis and allergy to ryegrass pollen are at risk of thunderstorm asthma if they live in or are traveling to a region with seasonal high grass pollen levels, even if they've never experienced asthma before. So we would educate them on thunderstorm asthma, give them an explanation of how to recognize asthma symptoms and what to do, how to get a reliever medication, educate them on correct device use, and provide asthma first aid information to them. So this group of people with allergic rhinitis but no asthma would be able to access a reliever medication such as Ventolin over the counter, unless their GP prescribes an anti-inflammatory reliever such as Symbicort or Seretide for pollen season if they are at risk of getting asthma. Then medical management for the lucky people who do not suffer from allergic rhinitis, nor do they suffer from asthma. We would reassure these guys that their risk of thunderstorm asthma is low, but still really important to raise their awareness of asthma first aid, because the more people that can assist with asthma first aid in the community, the more lives will potentially be saved in an emergency event. And hopefully we won't have another episode like we did in November 2016. Excuse me. So importantly, we need to remember that asthma is frightening. It's frightening for children, for adults who are suffering for the exacerbation, but also for the parents or the families or the carers. And severe or life-threatening asthma exacerbations are more likely to occur in patients with inadequate medical supervision. And in the absence of medical supervision, which clearly is not always possible, especially if an exacerbation occurs in the middle of the night, then our written asthma action plans will clearly explain the steps to take to manage someone's asthma day to day and what to do during an exacerbation or an asthma emergency. So written asthma action plans need to be individualized. I know that seems obvious, but you'd be surprised at what I've seen handed out to patients. So it should be an individualized written asthma action plan so that a person can recognize deterioration of their symptoms and respond appropriately according to what medications they have been prescribed. And it's expected that all children and adults with asthma should have a current asthma action plan. What should be included in the written asthma action plan? So all of the following: the person's usual asthma medications, including treatment for related conditions such as allergic rhinitis. So if someone's taking Symbicort 1 puff morning and night, but they also have allergic rhinitis, we'd be also popping down Nasonex, 2 squirts each nostril per day. It would also contain clear instructions on when to take extra doses of their medications or how to change their medications, introducing a new one potentially, including when and how to start a course of oral corticosteroids. The action plan should also show when and how to contact a doctor or when to go to the ED in an emergency. It should also have the name of the GP or other health professional preparing the plan, and it needs to have the date that the plan was issued. Around this time of year, also we can add in advice about epidemic thunderstorm asthma. That's particularly relevant for Melbourne and southeastern Australia, as I said, and also where to access pollen counts and thunderstorm asthma forecasts, who is at risk, what to do if asthma develops, and how to avoid thunderstorm asthma. That can all be included on an action plan as well. But individualised written asthma action plans consistently improve asthma health outcomes. They significantly reduce the rate of visits to acute care facilities. They reduce the number of school or work days missed. They reduce nighttime waking and improve symptoms. These are two of the most commonly found action plans, or commonly used, maybe I should say, in primary care. On the left-hand side is the National Asthma Council Action Plan. On the right-hand side is the Asthma Australia Action Plan. For those of you who don't know the difference between the NAC and Asthma Australia, the National Asthma Council are health professional based. So we write the guidelines for the health professionals to follow and a lot of resources, whereas Asthma Australia are more consumer based. So they do a lot more to do with patients. They have asthma educators available, etc. So that's just the difference between the two organisations for those who may have always wanted to know the answer to that question. But both of these plans, as you can see, are colour coordinated. Green for when the person is well, yellow for when there's a bit of a flare up or an exacerbation, orange for when there's a severe exacerbation, and red for when there's an emergency situation. Plans can also be generated using GP medical software such as Best Practice or MD, or they're also provided by hospitals. The Royal Children's Hospital have a great little action plan too. So for all children with asthma, their written asthma action plan should be reviewed by a doctor or a respiratory specialist every 6 months. And for adults, it's every 12 months. And then in addition, they should be reviewed whenever a patient's asthma control status changes significantly or their medications are changed or ceased. So this is the community first aid protocol, also known, and you may have heard it be called the 4x4x4 principle. So we give 4 separate puffs of SABA via a spacer. So SABA is short-acting beta agonist, otherwise known as relievers, i.e. Ventolin, Asmol. So 4 separate puffs via the spacer. For each of those puffs, you want the person to take 4 breaths. So like tidal breathing, 4 breaths per puff. Then you wait 4 minutes, and if symptoms persist, we repeat those steps. So 4 separate puffs of SABA via a spacer, take 4 breaths for each of those puffs, and then you wait 4 minutes and repeat if necessary. If there's still no improvement, we'd be calling the ambulance or getting someone else to call the ambulance for us and continue giving the 4x4x4 until help arrives. Of course, we'd always stay with the person, try and keep them sitting upright if possible, try and calm them and reassure them, and we are usually administering the medication for them. These are the 2 latest charts from the National Asthma Council from this year. There's obviously one, as I hope you can see on the screen, for children under 12 and one for children and adults over 12. In addition to SABA or short-acting beta agonist, one of the new guidelines is for patients who are aged 12 and over who may be using that preventer medication that I talked about since the new guidelines came in 2021. So they may in fact be using Symbicort or Foster as their normal reliever. So asthma first aid can also be delivered using those combination inhalers such as Foster, Duoresp and Symbicort. So these 2 new charts are also available on the NAC website. If they're using a Symbicort Turbuhaler, it would be 1 inhalation every 4 minutes. If it's the Symbicort Rapihaler, it would be 2 puffs every 4 minutes. But you can find out more information at that link there on the screen. So that's the big change, I guess, in asthma first aid, that you may come across someone on a sports field or a sports stadium and they're pulling out their Symbicort for asthma first aid. Don't go up to them and say, what are you using that for? It is becoming more and more common. In fact, a couple of hospitals in Melbourne have already started using that in their emergency departments. So using those combination medications rather than the short-acting beta agonists. So it's an interesting space. So how do we prepare for springtime thunderstorm asthma season? I'm assuming that there's mainly practice nurses out there tonight or GPs. So at our clinics, what do we want to do? Well, we want to prepare early. We need to proactively review our patients with asthma, especially those with a history of springtime asthma or allergies or previous thunderstorm asthma. You could complete a database search. So take the chance to pop into your database, patients with asthma, patients with allergic rhinitis, patients on Ventolin, patients on preventers, and you'll come up with a plethora of different patients, I guarantee. Take the chance to have a telehealth to review your patients. I think it's still quite popular for patients to have telehealth these days. Be aware of high pollen and thunderstorm weather forecasts at the clinic. Ensure that your Ventolins, your Bricanyls are in date and have an adequate supply. Also, the supply of spaces. Make sure that you've got enough spaces. It should be 1 spacer per person. It also should be now, since COVID, 1 canister of medication per person. And I realise that in an emergency, that's not going to happen, but that's what the guidelines say now. The good spacer to have, I'm not sure if you've all heard of them, are light airs. So LITE airs, AIRS, light airs. They're a rectangular collapsible cardboard spacer, very easy to store, much easier to store than the Breathitex. You can store probably 50 light air spacers to 15 or 20 Breathitex. So if you haven't come across them, contact your medical suppliers for all your different spacer options, but definitely have a look at the light airs. It's also important in clinics for there to be a policy for patients presenting with asthma exacerbation, and all the staff, including the medical receptionists, and of course the nurses and GPs, should be aware of each person's responsibility, right from the front door down to the back at the nurses' station. Train all the staff in asthma first aid, have charts on display. You could have patient brochures in the waiting rooms regarding allergic rhinitis and thunderstorm asthma and the different pollen counts. You could have an article in your newsletters that go out weekly or fortnightly or monthly and really promote that awareness. And I just also like to mention our colleagues at Asthma Australia. They have a 1-800-ASTHMA confidential free health service. Just by calling 1-800-ASTHMA, it's delivered over the phone by trained asthma educators. So it's just like having an asthma educator in a consultation with you, but it's just not always easy to get into a respiratory nurse or your GP. So a great option is that 1-800-ASTHMA number. For anyone who's a pharmacist out there tonight, as I said earlier, throughout the thunderstorm event in November 2016, many people presented to pharmacies for medical assistance. Again, ensure there's an adequate supply of asthma medications, an adequate supply of spaces, have a pharmacy policy for patients presenting with an asthma flare-up, a thunderstorm asthma pharmacy screening protocol is available from the NAC, but that's not only relevant for pharmacies, it's also relevant for clinics as well. So feel free to pop onto the NAC's website and have a look for the screening protocol. And again, for all staff in the pharmacies, they should all know their responsibilities and prioritise these patients who attend. Train them all in asthma first aid, have charts on display, and even know where the local GP clinics are and which ones are open and able to assist if a patient does present to a pharmacy, and you can say, okay, the clinic on such and such a corner is open until midnight, or this clinic is open until midnight, etc., etc. Any help will be of an advantage to someone who's having an asthma flare-up or thunderstorm asthma presentation. If any patients come into a pharmacy requesting hay fever medications or intranasal corticosteroid sprays or antihistamines, always ask about their asthma symptoms and recommend a GP review if asthma symptoms are identified. Other thoughts to consider: does your clinic have an emergency asthma plan policy? Who is responsible for the different aspects of care? Is there a consistent approach to emergency asthma management? Does everyone in the practice know where reliever medications and spaces are kept? And for more advice or thoughts to consider, you can refer back to the handbook. So these are just summarising the resources. I've pretty much gone through them all and you've seen them all on your screen tonight, but the Australian Asthma Handbook, the National Asthma Council for all your action plans, medication charts, first aid charts, allergic rhinitis charts and information papers, our how-to device video library, and there's also some spirometry infection control recommendations on there as well. And then we have Asthma Australia with the 1800 asthma phone number there, and Askia, where you can find the allergy treatment chart. It's the same organisation that produces the anaphylaxis charts. And since our audience tonight is from Melbourne, I like to always talk to the Victorian audiences about the Victorian government and their Thunderstorm Asthma public health campaign. So the Department of Health, with this campaign, aims to ensure basically that all Victorians, and in particular people with asthma or hay fever, or both, are as prepared as they can be should another thunderstorm asthma event occur. So they're all great resources and links there that you'll be able to access after tonight, because you'll all be able to access these slides. It's going to be up, I think Yvonne's going to keep it up for 4 weeks, but I strongly recommend that you have a look at those resources as well. I also wanted to talk to you guys, being from Northwest Melbourne PHN, about the Community Asthma Program. So as you may or may not be aware, Melbourne's Inner West has a number of community-based nurse practitioner-led asthma programs, and the local community health centre CoHealth has a free community asthma program known as CAP, or the Community Asthma Program. It provides asthma education and support for under 18s with asthma or Ventolin responsive wheeze. And asthma educators work one-on-one with children and families, providing information and education using telehealth, clinic or home visits, and utilising interpreters when they're needed. And they can also liaise with childcare centres, kindergartens or schools, in addition to GPs and or specialists. So the CAP process is, as you see on your screen here. So children and their families can be referred to CAP by their GP or other health practitioner, such as practice nurses or pharmacists, or families can actually self-refer. So I just wanted to pop those up because that's clearly relevant to you guys who are out there tonight, being from Northwest Melbourne. And that's it. So surely someone must have a question for me now, and I'll turn my camera back on. I'm glad that we didn't lose connection there, Yvonne. That was good. I've had a couple of dicey episodes in the last few weeks, so I didn't want to take any risks.
No, you were perfect. All done perfectly. We do have a question, and I'll see if I pronounce this correctly. What is the role of montelukast?
Montelukast, yes, it does have a role, especially in allergic rhinitis. However, there have been some studies that show that montelukast can bring on some hallucinations, some depression, and some other mental health issues. So definitely not as common as what they once were, but they definitely do have a role in the moderate to severe allergic rhinitis treatment, you'd be able to look it up back in the flowchart in the presentation. But definitely not as useful, or I shouldn't say not as useful, but definitely not as common because of those adverse reactions that they've found, particularly over in the United States with all the trials they've been doing.
Great, thank you. The next one I've got here is, we've had a lot of thank yous and great presentation, of course. I've got a question. Are you able to share which EDs in Melbourne use combination puffers for acute asthma? It would be good to look at their procedures / policy.
The Austin definitely use it already, and the Alfred are looking at bringing it in their care healthcare pathway, but not as yet, but definitely the Austin. So jump onto the Austin's website and you'll find that it's in their emergency department policy.
Great. And then another one we have here is, how young can intranasal corticosteroids be prescribed?
It depends on the corticosteroid spray, but usually from 12. It would be with 90% of the sprays, it would be from 12 years and up.
Great, amazing. And that's it at 8:02. I think that's it. I've got a couple of people putting their names into the chat, so that'd be really good. If you don't think you've come in with the correct name, please pop it quickly into the chat while you have time. Otherwise, our lovely Jen at the back end has put up the conclusion slide. So you will be receiving a post-session email within a week, which will include slides and resources discussed during the session. Attendance certificates will be received within 4 to 6 weeks. RACGP CPD hours will be uploaded within 30 days. You can see there's a couple links there. So there's a link there to the Northwestern Melbourne PHN events page, as well as our resource library, where you will find all the recordings of our sessions. And like Narelle said, we will have this session recording up online for 4 weeks. There's also a QR code there if you would like to scan that and tell us what you thought of the session, if there was anything we missed out on, any other sessions you would like about asthma. If you want to hear Narelle talk more about another topic, let us know. All about asthma, that's Narelle's the person we go to. Otherwise, like I said, there's lots of thank yous and great presentation in the chat for you, Narelle. Thank you.
Thank you.
So no more questions. 8:04. Do we call it an evening?
I think we can call it an evening. I have to go to night duty now.
Oh,
this
bless
has
you.
kept me awake and active. So thank you to everyone for coming on, and I hope everyone has a good sleep. Think of me.
We will. Thanks, Narelle. And thanks a lot, Jen, for doing all the back-end support and keeping us on track. Thanks a lot. Have a good night, everybody.
Thanks,
Bye.
everyone. Bye. Thanks, Yvonne.
Bye.